So a word about pharmacologic therapies. Some residents will benefit from vaginal estrogen and bladder medications. This does require consultation and referral, and you can start with a primary provider, continence specialists like myself. Gynecology and urology also are other options for you. I want to just talk to you a little bit about vaginal estrogen. It does improve the vascularity, muscle tone, and structural integrity of the urologic tissues. It reduces the risk of urinary tract infection. It helps improve urgency. And it should never be given in an oral or systemic form. It should always be given in the form of an estrogen ring, which is the est ring. There are two estrogen rings. The other one is the fem ring. That should never be used because it is systemically absorbed, whereas the est ring is locally absorbed. The idea behind that is that the primary provider, or if you have learned how to do this, you can insert the est ring into the vagina and it's worn for 90 days, taken out, and then a new one put in. Vaginal creams are another way, and what's nice about that is you can use it inside the vagina or you can use it externally as well to help improve the integrity of the urethra. And then as an alternative, vaginal tablets. We don't tend to use those quite as much because they're really hard, they're very small, and it's hard for residents to be able to self-insert because of their finger dexterity, and sometimes it's hard for the nurses also. We have some residents who do use them, but most commonly vaginal cream and the est ring are the two most common forms of estrogen that you would expect to be helpful. Pharmacologic treatment also can include anticholinergic or antimuscarinic medications. These are only effective for overactive bladder and urge urinary incontinence. We do not have any medications that are truly effective for stress urinary incontinence, and so that's why it's really important that you know what type of incontinence somebody has, and that you recognize that even if they have overactive bladder and urge urinary incontinence, that you need to be really careful about using these medications. Older adults do experience an increased risk of side effects. There's this whole issue with kind of a leaky blood-brain barrier for metabolizing, and there is a cumulative effect because many of the medications that they're already on have anticholinergic properties as well. So what happens, or the way that these medications work, is they target the muscarinic receptors, and there are muscarinic receptors in the bladder, most definitely. However, I put this up here because I want you to see that there are also receptors that are located throughout the body. And so when you see that the eyes, the GI tract and salivary glands are affected, as well as the bowel, you can see why the side effects of dry mouth, constipation, and sometimes episodes of confusion can certainly result from using these medications. So what happens is, in overactive bladder or urge urinary incontinence, the bladder is acting in a very uncoordinated way. And so with these medications, they're acting as a direct smooth muscle relaxant, and they help settle the bladder down so that it can fill more completely and empty more appropriately. And so there are residents that this will work really, really well for. Most common side effects, as I said, blurred vision, confusion, dry mouth, and constipation. And it's really important that you not use these medications for older adults who have narrow angle glaucoma, and that any oral medication that you use should be started very low and gradually increased over a 4 to 6 week period of time, monitoring for side effects. Avoid short-acting doses whenever you can. They have a much higher side effect profile. Extended release is better tolerated with fewer side effects. Monitoring for side effects, as we talked about. For some patients, you might want to get a baseline, mini mental status exam or an animal fluency test, just to have a baseline for cognitive function if there are changes. It does take about 4 to 6 weeks for these medications to begin to get a therapeutic effect, so increasing the doses quickly are not the way to go. And repeating your bladder diary to determine whether or not they're effective at that 6 or 9-week mark might be a really nice way to go. One of the things that I want you to know is that oxybutynin, which comes in several formats, oral as well as transdermal, this transdermal piece is really nice because it can be in the form of a patch or it can be in the form of a gel. And both of those are really, really helpful and a nice alternative, particularly when people can't take medication or don't want to take another oral medication. Incontinence devices, these are devices that are designed to support the pelvic floor, and they're used for women. And we talked a little bit about the relaxation and displacement that can occur, and pelvic floor weakness is almost always a part of this process. And so using a support device called a pessary is often really helpful to repositioning the pelvic organs and getting everything back in place. So this gives you an example. So here's the bladder, and here's the uterus, and the uterus has slipped down into the vagina. And so when that happens is it's putting pressure on the back of the bladder neck. And that can cause incomplete emptying, it can cause urinary tract infections, it can cause dribbling, it can just cause lots of different things. Plus, having your uterus prolapsed is really uncomfortable, and women will often complain of pressure and low back pain and just not feeling good. Cystocele is when the bladder itself relaxes and starts to fall down into the vagina. And so again, having a supportive device that will move that back into correct position is really nice. And you can see how having a supportive device to move this back into a correct position is really nice too. You can also have surgery to correct this, although, as you know, most of our older adult women are not necessarily candidates for surgery due to their age and their other chronic health problems. The rectum also can relax, and this enterocele has to do, you don't see this very often, but this is when somebody has such extreme relaxation that the peritoneum is actually prolapsing down into the vagina. So none of these are good situations to have. All of them can contribute to bladder symptoms and problems, and all of them can be corrected to a certain extent. So here's an example up in the corner of all different kinds of pessary devices. These do need to be fitted. Perhaps the primary provider or a nurse practitioner who comes to your facility would be able to do that. I know in my role as a continence specialist, I do that, but I have other facilities where residents will travel to gynecology to be fitted and have these corrected. They do have to be changed or cleaned. We call that pessary care, and they're removed and washed, and the tissues of the vagina need to be reassessed to make sure that there's no abrasion or erosion that's happening because of the pessary. Most commonly, using an acidic gel, such as a Trimisan gel, or using vaginal estrogen is used in conjunction with the pessary to get the best result. Let's see, so consultation referral we've already indicated for estrogen replacement, for pharmacologic treatment of URGY, and also BPH if you've got somebody who has an enlarged prostate. There are prostate reducing agents, we didn't talk about that, but there definitely are, as well as incontinence devices.